Hi everyone, just waiting a little bit to get some. Oh, there we have our guest here. Let's see. Hello.
Hello, how are you?
I'm well. How are you?
Hey, it's Thursday, right? That means we're a day closer to the weekend.
Very true. So true.
So true, yes. Well, I'm happy to be here again. Well, be
Yes.
not again. I'm
Well,
happy to be here with you this time again.
yes. Yes. Agreed. How's the weather in Colorado?
Um, Cloudy,
Oh, has the
cloudy.
is it? It's usually sunny though. Well, yeah, it's usually sunny for you
Yeah,
guys.
pretty sunny. Yesterday was like 50s. It's still t-shirt weather. So we're going camping for Thanksgiving, so it'll be lovely.
Fantastic. Do you go up to the mountains?
No, we're actually going to go to Moab so that we can
Oh,
canyon lands and that kind of stuff. It will be a little bit warmer there, so we'll find out. I haven't camped there over Thanksgiving before, so hopefully it's um, t-shirt weather. I mean,
yeah.
at least you can get outside.
Yes. Yes. And stay outside and sleep outside and
Amen. Yep. Yep.
yes. Well, I guess we can get started. So I'm Dr. Kimberly Santiago of AirSync Integrative Dentistry. I'm a dentist, tongue-tie surgeon, and a face jaw airway architect. I should trademark that, but um,
I was thinking about that the other day. I'm like, no, what did she say about architect? I got to use that. So,
it's
yeah.
awesome. And I was sitting in a class. Sorry, I always go on sidetracks. I'm so sorry. But I was sitting at a class and it was more dental than airway, but they were talking about smile architecture. And I'm like, hello, thank you. I already had come up with the architect prior. But uh,
Perfect.
anyways, so I'm excited to have a guest joining us from Colorado. We have Miss Carmen, who is fantastic. I saw some of your pictures recently on Instagram, and I was like, oh my, the recent range of motion one. I was like, wow. But please introduce yourself.
All
And
right.
yeah,
You guys, I'm Carmen Woodland. I'm a myofunctional therapist. I am in Colorado. However, I have a large global online myofunctional therapy practice. So I do see a lot of people in Colorado, but I see people all around the world because I do this online. So
yeah.
thank you. Isn't that crazy? I just had a release this morning with a doctor in Washington, D.C.
Ah,
Literally, as she was walking out, she had gauze in her face, looking like this from all of her releases, and everybody is just loving those pictures, that those range of motion, and both the tongue ones and then this neck thing.
be able to, yeah.
Yeah, so I love it. Because I had never had a tongue tie, I live vicariously through everybody else. So I always am so excited about this session, this post-procedure session with clients, because I'm always like, yay!
Let's see what you can do.
Yeah, what did you learn? What did you learn? What did you say? What did the doctor say? So I love it. But thank you for having me.
Yes, yes. Yes, I love talking tongues and airways and babies and all sorts of, yep,
All, all the things, all the
all
things.
the things. So today we're going to be talking about, uh, I think the most important thing of what we have planned is really how to pick the right team, how to vet, how to select, how to interview, how to research, who to listen to when there's conflicting opinions, and then just some of the general signs and symptoms, how this is not a fad. Myofunctional therapy has been around for decades, tongue ties centuries, and then the de-evolution of the jaws and airway problems and sleep, which we're not quite going into, but that's been happening it's been around for many hundreds of
For a
years.
hot, for a hot minute, right?
Oh yeah. Oh yeah. It seems like a hot minute because now we're all talking about it. But so I guess how long have you been doing myofunctional therapy?
So I'm in year 5.
Okay.
And I learned about myo really early on in my hygiene career. So I learned it, but I didn't know, and I'm embarrassed to say this. I feel like it's a lot like how orthodontists learn about the airway and then they're embarrassed to look back,
Yeah.
because I learned it. I learned it, of course, from this standpoint of close your mouth. gum health, that kind of stuff. So I learned it very early on, and I knew enough to be dangerous, but I didn't know enough to, have conversations confidently.
Mhm.
And then when I started, so I call it the dark side of dentistry. And I know that you can appreciate this also, because most dentists, and when I say most, 9 out of 10, it's hard to say, but it's so hard because they just say, I don't even know that they think it's a fad. They just don't think about it.
Yeah, it's true.
And it's like, oh, do you have a tongue tie? No, stick your tongue out. No, you're fine.
Yeah. I think the opinions, if you'll agree, come from the pediatric, and please forgive me if you're a medical provider on here. I'm not trying to denigrate.
It is the truth, and it's interesting. I just started with a new client. Her dad is a pediatrician and her mom is a pediatric nurse.
Ah, okay.
And she has a very significant tie. So I just met with her recently for session number 2. And I said, so how did that go with your parents? And she's like, my mom is completely closed to it, doesn't understand it at all. My dad, she gave him Dr. Baxter's book, Tongue Tied, and she said he's reading it.
Oh, well, that's a start.
I said, hey, that's a start. And I always, so when we apologize for beating up medical professionals, it's not intentionally, but we embrace people who are willing to learn. And so when people, I can think of one little boy here in Denver I sent to Children's Hospital for a sleep study. He's a little boy, failure to thrive, and had a tongue tie. I was the third person because they called the orthodontist. The orthodontist said, well, you got to call this guy. And this guy said, well, you got to work with Carmen first. So 3 people, had already said, hey, you have a tongue tie. But I was concerned for childhood sleep apnea. And I sent him to that specialist. And, 5 minutes in, the doctor looked at the little boy and said, yeah, you have a tongue tie, but it's not causing a speech impediment, so you're fine. And no, you don't have sleep apnea because you're skinny. Mm-hmm. And I told Mom, do you want to fight for your kid or are you going to accept this? And she said, well, I want to fight for him. I said, okay, get another opinion. Guess who has moderate sleep apnea? It's
not who we think they are.
Yeah. And so I was so happy with that ENT because he was like, hey, please have Carmen reach out to me. I want to know more. So while he was very antiquated in his thinking, he was at least open to learning. So
and that's really what pushes everything forward, whether it's in dentistry, in airway. I mean, that's what pushes medicine and science forward, is changing your lens and questioning things and being open-minded and
being willing to learn. Yep, absolutely.
Yes. Otherwise, we're stagnant if we don't if we don't ask why. Or let me learn a little bit more about that.
Yeah, absolutely.
So, okay. So one question, or the first, I guess we can maybe not move on, but we'll start with signs and symptoms that we see in adults, and it applies to children too, but a little bit different animal. So do you want to talk about, I guess?
Absolutely. So what I do is I'm going to cheat you guys because I have my clients use what I call a discovery checklist. So when I meet with a client for the first time, I don't want to just theoretically talk about, and Kimberly, you probably do the same thing, like you have them fill out some paperwork so you know something about them. Yep. You're looking at them in person, whereas I'm looking at them virtually. But I have them fill out this discovery checklist. So they can self-identify. And I think you mentioned this last time when you and I were live. So when they fill it out and they see that they left no ink in their pen, like, hey, we have a concern here. So when we're looking at signs and symptoms of a tongue tie, now remember, these are probably not all inclusive, but I can't tell you how many boxes there are on this paper. But I divide things into infancy, early childhood. And the reason that is because, right?
Yep.
Yep. You're born with it, you know? So if we have a kiddo that has breastfeeding issues, that's a big red flag, but it's not the only one, you guys. There are plenty of kiddos that say, oh, I was just happy. I was just great. I was fat and sassy. And by fat and sassy, they mean big overdeveloped cheek muscles because the kiddo is working so hard to have that transfer of milk. But when a kiddo works so hard and falls asleep at the breast, you guys, and mom's a 24/7 buffet, guess what?
That's awesome. Sorry. That's awesome.
But But it's true.
It's true.
When moms are like, I just had to nurse all the time. And when the kiddo falls asleep, that's because it's a lot of work. So it's like doing some squats and some lunges. Whoo, I'm exhausted. I got to go to sleep. So while a lot of kiddos with the tongue tie have, you know, acid reflux, they're spitting up, they're gassy, you know, that kind of stuff. We also have these happy babies that are just like little cherubs, but they're working so hard here. So we see those symptoms all the way back to infancy. Irritations is a common one. Then I look at airway breathing concerns. Then I look at oral resting posture. Family tongue ties. So many people come to me and they're like, yeah, I've got 6 children, all have tongue ties. Well, it's the gift that keeps on giving. It's coming from somewhere, right?
Yep.
And so then dental stuff I look at. Really, okay, can a kid not, is there a high decay rate? Can a kid not clean their teeth, or an adult?
Yep.
Use the tongue as a tool. Well, the tongue is meant for more than talking, you guys. It's helping to chew your food, keep it on the teeth, create and manipulate a bolus so that you can correctly swallow, which anybody with a tongue tie does not do.
Right.
I don't care, you know, and I do hear that argument a lot. You probably do too. Well, I swallow just fine. You can't.
I roll my eyes, but yes, agree.
Yeah, you can't, because, and that's just physiologically, because the correct swallow starts with a suction, and can't suction all the way back to the soft palate to get that lingual palatal suction. You can't swallow, so you compensate, and that's the biggest thing, is where people, you know, they'll email me, hey, I don't have a tongue tie. Well, how do you know? Well, because I looked it up online. Dr. Google is great. I said, oh, well, so you saw the worst tongue ties.
Yes.
But the most common.
And you would agree, it's about function. So we need to assess our patients, not visually, but with function. And for me, it's also, but I'm looking at patients a bit differently, and like you said, in person, but all of the comorbid changes to the anatomy, or what's happening with their sleep. For me, it's putting it all together. But well, yes.
And that's what I was just going to say, is sleep. So when I look at their discovery checklist, I'm looking at all of these things, you know, their complaints, their upper body tension, which I say is the drug of choice everybody is coming to me for. Like, please just help me with this. And the crazy thing is, but they might have a fatigue severity score of a 63 out of 63 because they're not sleeping well. Their cells are making no energy. They're not exercising. They're not eating right. You know, all of those things. But all they're worried about is, could you just make me feel more comfortable up here? But I'm snoring and I'm sucking the curtains off the wall at night, but nobody has told me that that's a problem.
Yep. But as you would agree, the tie is just the tip of the iceberg. And there's all these descending problems and the iceberg that's hidden under the surface too.
Exactly. And so all of those, I mean, you guys, for whoever asked that question, there are so many symptoms. Digestive issues, that tension, the sleep, behavior problems. Obviously, I don't see a lot of behavior problems in adults. I think all adults have behavior problems, but that's just, you know, that's called mommyhood, right? But there are so many things. The problem is you have to seek out more information. Don't just look up a picture. Don't post a picture on the Adult Tongue Ties Facebook group that says, hey, do I have a tongue tie? Because unless you're what we would call, both of us would call, the low-hanging fruit, it's obvious. Some people are really obvious tongue ties. But in my world, and this is probably different, Kimberly, from yours, is a lot of my world, you know, when we talk about that insertion point of the frenum, a lot of doctors, you know, they'll look at this free tongue and they'll say, oh, you're fine. Or, oh, you can lick an ice cream cone, but you're fine. But what about this?
And that's the most critical.
This can't get to the roof of the mouth. And so when I ask people, so what did your doctor do? Oh, they had me stick my tongue out. Okay, so the genioglossus works.
Your ice cream licking is probably impeccable. Your ice cream cone licking.
Yeah. But what else? And so most of my world is this. I literally have a client right now who can stick his tongue behind his uvula, behind it.
Oh my God, that's crazy. That's crazy.
But he can't,
Oh,
like his palatal suction is like, so it's so crazy. So there is so much, and you probably say this all the time, there is so much to the puzzle, which is why you have to have a comprehensive assessment to look at all of those things. So it's not just what that restriction looks like, it's the signs that, or the symptoms that go along with it. So I call it the myofunctional impairment. Because I used to say dysfunction, you talk about architecture. So you try and use words that are powerful. That didn't bother people. But if you say impairment, suddenly people don't want to be impaired. It's like, but it's about so much more. It's their craniofacial structure. So that's probably the first thing somebody comes through the door and you look at them and you're like,
oh yeah.
Oh yeah, airway concern, or this cute little button chin. This is not a cute little button chin. Sure, we love it on our babies, but we look at that structure.
Oh yeah.
So that's a big long answer to signs and symptoms. And
we don't have short answers for anything.
Right? It's still really gray. And it doesn't, I don't even get that answer until I do a functional assessment with somebody where I have them lift, put the tongue out, lateralize it. Can they click? Can they suction? Suction's a big one because they have to be able to suction for a release, at least in my world.
Oh yeah. Well, it's interesting how many, I'm assuming you do the tongue range of motion, the Breathe Institute assessment protocol. It's so interesting. So many patients know how to use the tip of their tongue, but I'm always surprised at how many people cannot even control motor wise the elevation. I mean, they get it in a little bit, and then of course with diligent practice, but nobody really thinks about being able to elevate their tongue. So
and it's so hard. And proprioception, like I until just recently, I haven't had clients that needed, like they couldn't put tongue to the spot.
They couldn't find the spot.
They couldn't find it. So that conversation with the brain and the muscles, like it's like dancing with two left feet. People will look at me, I understand it, but I just can't do it. But that suction, and I did see somebody just ask why the suction is needed for a release. So do you want to answer that? I have my answer, and my answer is from a dentist that says it's necessary to be able to do this suction to be able to get the correct intramuscular release. And so that's a great question for you because not all releases are intramuscular.
No, it's all patient dependent how you do the procedure. I mean, you have your guidelines, of course, but every tongue is different. So yeah, I use, you need to have very good tone and very good control of the tongue, but the palatal seal, the suction, it's so I can see how much I need to release is the first part of it. But we have them doing myofunctional, not the exercises, but we have them doing the suction hold and their tongue to the papilla. And I think maybe everybody on here knows what those things mean, but the tongue to spot is right behind the teeth. I am not super talented with my tongue, but I'm actually tied.
8 hours a day.
Restriction. But there's a lot of muscular recruitment that we need during the procedure, and the tongue fatigues. And so we don't want a floppy, wet fish. I don't know, that makes no sense. But we need a toned tongue. So the more strength there is, I can see the muscles are more clearly defined. There's a lot less bleeding. But we need to be able to see, and then you can actually see the range of motion improve as well as you release the fascia. So yeah, I let my myofunctional therapists, whomever they are, if it's somebody in my office or people in the community, they get my patient ready, and that palatal seal is crucial, just like yours.
Yeah, and that's one thing. Now, I will say I have had some of the worst tongue ties that some of my doctors have seen. In those cases, I'm like, could we just have a release tomorrow, please, and give me something to work with? Because there are those people. Yep. But when I have somebody work on that release, my benchmark is it's about 5 times more what Dr. Zoggy's is. And the reason is because I have people come from elsewhere to see him, and they're going to forget, but I have them work on that seal 5 60-second holds. And it's funny because my provider in DC yesterday said, I want him to do 60 seconds. And I'm like, that's nothing. So I have my clients be able to up and down, hold those holds. Not that anybody's ever going to have them do that suction and hold for 60 seconds at a time, but I have many of my clients. Most recently, a guy said, "Carmen, I lost track at 16." So you guys, that's like squats. That's like up and down, down, up and down for these muscles. And the biggest thing is I want my providers to be able to see what they're doing. So I always say, like, we don't want Kimberly to have a moving target. We would like her to be able to see. So I actually do a combination, because I do the suction and hold, but then I also teach tongue on spot open wide, so that they can just, no quivering. I want them to be able to hold it for 90 seconds, because so many people can't even
sustain that. Yeah.
in that. So, and I tell them, like, hey, I teach you two different things so that the doctor can see what she's doing.
Yep. And an untoned tongue is a bloody mess. I mean, it's like, yeah, it's literally a bloody mess.
So that's a great question. So I have a personal question myself. So my DC provider yesterday said, I love them to be, so prepared so that I can get those blood vessels out of the way.
It's true. It's true. Everything just, the fibers are so much, I don't want to call them supple because they're strong, but they're just like very pretty, and they just like move away when you go in, and it's like you're opening the curtains almost, and it's just clean, and then everything just moves so much nicer.
I learned something. I had never heard that. So I was like, okay, I got to put that on top of my list to ask somebody, because I had never heard it put that way, of moving those blood vessels out of the way.
And it's true. Like, I have never, thank the Lord, I have never gotten into a vessel. There's sometimes like little surface vessels, that just little capillaries, and then it's so lovely that you do get a little bloody mess, but it stops pretty quickly. But yeah, the well-toned tongue, you're not going to get into that scary anatomy that can cause complications afterwards. So I never really articulated it, but I see it. So.
Yeah, well, and I just hadn't heard it that way,
Yeah.
Of course, my world is a little bit different than your world, and it's even harder for me. Like, you just know your way. Like, you've probably seen other releases, and train, that kind of stuff, but I have thousands of people all around the world, and I'm like, I don't know. I don't know, but I always, when something like that comes up, I'm like, and all doctors have their different requirements. And so that's how I knew when I asked somebody, because I had a provider who, their office, we had several clients together, and he said, or his office said, hey, we're just sending out these pre-procedure requirements that we want everybody to meet. And some of them were really advanced. And so you can probably weigh in on my opinion here. So some of them were really advanced, and I was like, that's weird, because I don't teach that until after a release, and probably 2 or 3 sessions in, when we can get to that point. So I was a little bit like, so I polled all of my providers in the United States saying, okay, so I have a question, because I want to make sure that I'm doing things correctly, because I had some releases where they weren't having them do the suction and hold. And I thought that has to be done, And so it was nice to find out that my standards were well beyond what anybody needed. But some of those other exercises, I thought, there's no way that people are going to be able to do those. So what would you say to that?
Yeah. Well, I probably need to up my game, and I've just always put my trust in the referring providers. And yeah. I like the concept of the provider sharing that there's certain requirements, because not everybody's going to be amazing like you. There's a lot of myofunctional therapists with varying degrees of experience and abilities and focus with their patients. And so I like that concept, but it is a progression, and you know better than I do, but you have to build on the skills. And until you get more range of motion of the tongue, you're not going to be able to progress to the more advanced techniques. But just back to your comment a few minutes ago, sometimes tongues do need 2 stages. So if they are tied to the tip, I like to do a mucosal release, just to the muscle, not between the muscle. That way the patient can then progress with
then they can start
Yeah.
myofunctional.
Yeah.
And that's the biggest thing is that they have to be able to we got to have something to work with.
Yep.
You know, and if I have a kiddo who's so tied, or an adult, like I see adults that are that tied, and they had no idea.
Yeah.
They had no idea that they can actually have their tongue in the roof of their mouth. But sometimes I do have to say, hey, can we get a release like right away? You guys, for those of you who don't know, like when you do this release, it's like a run in the pantyhose. You start to open it and it just,
yep.
And it is the craziest thing because, and everybody's wound is different size, but like when my granddaughter had hers done,
You have a granddaughter?
I have 3.
You look amazing. Wow.
I'm older than I think. I'm older than I think. I'm older than you think. But yeah, so when my granddaughter had her release done at 7, when I saw it, I was like, girl, you could probably lose a marble in there, you know, and that's the biggest thing, is it just starts to have that release. So when we have somebody who has a significant tie, 2 stages, and 2 stages means twice.
Oh, sorry. Thank you. Yes.
Like you're just going to have that done again. And nobody's ever really excited about that. And I do have to push some people because we're going back to square one. But to be able to rehabilitate those muscles, that's super duper important.
Yep. And I know you'd agree, you know, it's really the oral myofunctional disorders that you're trying to correct. It's the tongue tie that's in the way. The restriction is in the way.
Barrier. Yeah. Because you can't fix. So like we were just talking about the swallow. You cannot swallow correctly with a tongue tie. You can't. You may not realize that, like clearly nobody has starved, you know, but it is with that compensation. And the longer that goes on, my oldest client that I started was 79. Do you know how hard
to unpeel and unwind? Yeah.
And she had been swallowing wrong for 79 years plus.
Actually, since 4 weeks in utero.
Yeah. So
30, I know.
Yeah. So almost, you know, almost a year longer than she had been alive. And so I always say my older clients, for you guys here who are older, I always say my older clients, half are mad and half are mad. Because the half that are mad, nobody looked. Nobody understood. Nobody ever said anything. And then the other half are mad because they knew there was a problem and they didn't know that they could do anything about it. So then when I get a hold of them and we make huge changes in their life, then they're mad that they didn't do it 20 years ago when they knew that there was a problem. But you talked about a tongue tie being a fad and that they've been around forever. So the whole pinky thing, I love that. So tell people that this isn't a fad.
Yeah. And I don't know how they didn't slice vessels.
I know.
It makes me stressed. It gives me like, ooh. But yes.
Or cause an infection.
Those fingernails are not, and God knows there were no sepsis or antisepsis or anything. But yes, so there's documentation in literature from France and Japan that midwives would keep a long fingernail so that every baby was assessed. I mean, not, you know, like what we do today for oral function and infants, but they would feel for restriction and they would slice it and baby would feed. So it's been happening. It's been around. There were even in the early 1900s and I think late 1800s, I found pictures, and you've probably seen them here and there, of the same kind of instrumentation that we use, the same instruments that we use to do the surgery, like the group director. So it's been here. It's but as the tides shift, just like oral myofunctional therapy was a process of therapy, you know, in the 40s and the 50s. And if you follow Dr. Kevin Boyd at all, he's uncovered research from, you know, the early 1900s that the dentists and the ENTs knew that the key to opening up the nasal passages to breathe through the nose was with orthodontic expansion. So things are known and then they kind of disappear, and God knows there's probably politics behind that. I don't know. But I think we have social media to partially thank for things now. The more aware, there's more awareness. Breastfeeding is, I hate saying in vogue, but more people want to breastfeed. And it's hard. You can't breastfeed very well if you got an impairment, a physical impairment. Mm-hmm. So I started my journey about 6 years ago into this, and started with tongue tie surgery. And then just my life just went whoop, and now all I do is tongues and airway development.
Like, that's all you think about is tongue. It's like, we cannot watch TV here in our house, and Scott will be like, mm-hmm. Yep. Or we'll be somewhere and mouth breathing, And so that was, going back to when I first learned about Myo, it was more about mouth breathing. And as a dental hygienist, and I see that there's some speech therapists in here, I always say, like, speech, we should all learn this and stuff in school. And I always feel like I beat up the speech therapist, because they should, a tongue tie is a physical barrier that holds a kiddo back from successfully completing speech therapy. Versus as a hygienist, my job was to probe teeth, look for periodontal disease, and remove calc. Okay. So I was doing my job. I was just doing terrible at it, because I would say, oh, look at this bloody swollen tissue. Oh, you're a mouth breather. We'll close your mouth. So I'm embarrassed looking back at what I didn't know, but speech therapists, it's so hard. So speech therapists that are Myo trained, they're so much better. But I really feel like we start with education, talking, awareness, and lifting and looking
properly and looking.
Yeah. And not just sticking the tongue out. I did have a question, and I just kind of got off on a squirrel tangent. I do that. I know, it's like shiny squirrel, right? I did want to ask you, so one of the biggest challenges that I run into as a myofunctional therapist is, I'm on the other side. I'm not the doctor. So when I tell somebody, no, you're not fine. No, you're not fine. And since one of our topics here was to talk about creating your dream team,
yeah,
I feel like by the time somebody gets to you, you're the doctor, so you're educating them. But what kind of advice do you have for people who are listening to us that are like, hey, I've been told that I'm fine. How do I have that conversation? I don't necessarily, my clients, I don't want them to necessarily continue that conversation with their doctor, because I don't want to talk somebody into believing that you have a tongue tie. Right. I want you to talk your doctor into doing the procedure for you, because everybody these days has a laser in the back room, and sure, I can take care of that. It's just, hey, I can lance that for you. So what do you say to those people?
Well, I mean, in your case, your clients, your patients, they seek you out. They're seeking they've identified a problem. And that was what you were referring to a little bit ago, is that it's the self-discovery or identifying your own problems as being in your intake forms. So people need to identify their own problems so that you can offer them a solution. So they've reached out to you. For me, they get referred, or they've read the book Breath by James Nestor, and then they call Dr. Balfour, who's in the book, and then he sends them to me. Anyways, it's kind of people don't just happen to pop into my chair. They're sent to me. So, but I actually have to do my fair share of pleading on their behalf, especially to parents for their children, and it makes me crazy. But I'm not giving you the answer to your question. So I do agree. I think a lot of patients have so much faith in their physicians, less so even in a dentist. And then not again trying to denigrate your skill level or your credentials, but I'm almost on the same level as you relative to a physician. Mm-hmm. But I think it is a conversation where they need to, if the physician isn't in tune with what their issues are or can't lead them in the right direction, it's time to get if they're looking for another opinion, a different provider. But there's not very many me's in the world. Like, I'm a crazy lady. I am incessant. I've probably taken almost 500 hours of CE this year, and 4 hours of today is in either Instagrams or Zoom. I'm talking for Airway Circle Lead. I'm just a crazy woman, and my children in my life are suffering. That's another story. But there needs to be more people like me to help validate and help treat these patients and create the awareness. And I don't know if I answered your question exactly.
No, great. Because I think the biggest takeaway that I think everybody should have is that we all do trust those people, but we don't know that they're up to speed. So I always say outdated and antiquated thinking, you know, they just don't. And so they just don't stay up to speed. They don't dive in. Ortho is another one. You know, you mentioned Dr. Kevin Boyd, and that's the hardest thing, I think, for me when I'm talking about tongue ties. Parents are like, okay, but then you start talking about ortho. Like for my 4-year-old, yeah, Dr. Howie Hinden the other night in our class saying that they just put expansion in a 3-year-old.
My youngest patient is 2.5. I treat the 0 to 6 years I do all the inpatient. I'm sorry, I cannot talk. I do all the new patient assessment and diagnostic workup and treatment planning, but hands-on, I treat the littles. And so I'm crazy lady, like I said, but that's when you got to do it. You got to get they're already suffering. So yes, I love the little, and they're so fun. They're really hard to glue things onto, but but they're, and you know, the parents, they've been searching for something for years. And that's something, you know, when patients come to you, they've already identified something's wrong with them. They just haven't been able to get the answers to what it is. And so I always just tell parents to trust their guts and find the answers not the opinion that agrees with them, but look for the answers. And just because you're told no or whatever, you can get 2 opinions, 3 opinions.
Well, and that's what I say, get multiple opinions. And when you start to hear the same thing twice, then that starts to make more sense. Or if something starts to make sense, or if somebody is helping you get to the root cause. And I feel wholeheartedly, you know, since we're talking about tongue ties, that is one, you know, the tongue tie is not the problem. It's a symptom. It's a physical barrier. And that's the biggest. In my world, everything else is the same. When they say, well, what if I don't have a tongue tie? Well, then that makes our life easier because we work on the breathing, we work on the tongue posture, we work on the tongue thrust. Oh my goodness. If I had $5 for every tongue thrust that I was supposed to fix, and it's like, well, we got to fix the other stuff because you guys, a tongue thrust is not a problem. A tongue thrust is the tip of the iceberg. It's a symptom of a bigger problem. Yep. But the physical barrier has to be taken care of. And I suppose before we end up wrapping this up, pre-procedure therapy, post-procedure therapy, you don't just go out and get a release unless it's a very, very severe release.
Right.
A very severe tongue tie.
Yep.
You have to do therapy. Like in my practice, I don't know what your experience is with your myofunctional therapist, but I start 2 months before. And that's so that we have adequate time to meet those expectations. But you can't you don't get to just go to the hospital tomorrow and get a new hip.
No, you have to prepare.
So if you're listening to this and something is making you go, you got to plan ahead.
If you walk in,
you're not getting one at Christmas. What was that?
Yeah, any provider, if they say, yes, I can do the surgery same day that you go for an eval, that's not a well-trained provider. And even babies now. So I started my journey with infant tongue ties, and then it turned into the Breathe Institute education, and then, you know, my world. But this year, just to bring in a little bit on neurology and cranial nerve dysfunction, I did the whole ALF series with Derek Nordstrom and Angie Tenholder. I've been doing ALF for a handful of years, but they really look at the function from a neurological level. And so I'm now not treating babies on the first day. And we're working on nerve function and integration and reflex optimization before we do the surgery. So it's almost like, and that's completely against the grain for what every infant laser tongue tie person does.
Well, that's what I was going to say. So what is that breastfeeding dyad? Like, what was that?
Say the first part of the
what does that do then for that breastfeeding relationship? If you're not doing the release immediately, does it affect mom's milk supply or that breastfeeding relationship? Like, how are you guys navigating around that?
Super good question. So when you do I guess we could talk about baby lace. Is that okay?
Sure.
Have you heard of baby lace? I don't know. Okay. So baby lace, you're basically doing what's called photobiomodulation. You're basically supplying energy to the muscles down to the level of the nerve. And it's actually absorbed by hemoglobin, which is really cool. I'm just writing a little presentation on it actually for later today. But so I was doing right up till right before I logged on. But it's a special wavelength. It's only available through the Photona laser family, and I think some medical lasers too. But basically, it's supplying energy to the system to not quite excite the nerves, but basically turn them on because they may not be working optimally. But all of these muscles are powered by nerves. Mm-hmm. So if we have a neurological component, and parents always freak out, and they're like, I'm like, it's not a brain organic problem here. It's the connection from here to here. Something got disrupted, and it's from either gestation or the birthing process. And so, so depending on how the baby presents and how, so my exam is not just on babies or even bigger humans. It's not just how does it look, but in babies, it's looking at how are their reflexes presenting, and do they look like they're sympathetically, which everybody means that's fight or flight. Are they dysregulated? Are they like, you know, the babies that are like constantly in agony because they have tight fascia as well as digestive distress, the colicky babies, the ones that are just angry. I call them angry because my son was that way. And that's what I didn't know 9 years ago. So sometimes if you have a baby that's coming in hot, as Dr. Angie Tenholder calls it, they're a hot mess. They're stressed, mom's stress. If you do surgery on that baby right then and there, it's not going to heal well. When you introduce a surgery or a trauma to a child that's already in this they're not going to have resilience to heal, and the parents aren't either. So I never have quick answers. I'm so sorry. But so if you delay it by just a week or two, and you're not delaying it, we do the baby lays immediately.
Okay.
And by doing that, you're actually liquefying the hyaluronic acid. So hyaluronic acid is what makes up the fascia, right? So in tight fascia, so a tie is a tight fascia, it's kind of gluey, sticky. I don't know if you've ever seen what it looks like under it looks like this like dense, almost like cotton candy spider webby. Like from the Lord of the Rings when they got wrapped up in that yucky stuff. It looks like that. Best way to put it. So, so by introducing the energy, it actually stretches and softens the fascia, and you're supplying this input to the nerve. So you're actually gaining function despite not treating the tie immediately. So baby so you're not just like, see you in a couple weeks. It's nothing like that. So baby will be in a better spot immediately. And then we ask them to go to craniosacral or osteopathy within 24 to 30, well, within 2 days or so, because then those healers can move the energy and distribute, you know, help the fascial restrictions from head to toe. So in some cases, they'll do one baby lays and then the next week we do the surgery. The super stressed out babies, it might be 2 or 3 sessions. So I don't ever want to impair mom's milk supply.
And she's probably pumping. That's what I was just thinking.
Exactly. Yeah.
She's most certainly going to be pumping. Okay. Yeah.
But moms, like I had one yesterday. So I do sometimes treat babies the same day. Okay. I would say it's like a third now. I don't even know. We just started doing baby lays like 3 months ago, and it's changed. Our outcomes are, I can't say like 100% successful, but there were always those babies here and there where I was like, they aren't healing well. And everybody's done the right thing. They did cranial, they did everything that we told them to do, and the baby still didn't heal well. And that's not where baby lays was founded or why it was founded, but it really makes, nobody looks at the neurology in that way. I know they're getting looked at from a reflex perspective with the pediatricians, but some babies come in and they're fine, and we'll just do the surgery that day. Like I had a little lady yesterday, 2-week-old, and mom was in absolute pain, but she had it's all about contraindications and properly diagnosing the patient. So So she was one where we could treat her. So I'm always an outlier, actually. Now I'm like probably like a pariah, but some cases, just like you won't do a frenuloplasty right out of the gate, you need to prep that human so they have success. So I don't know why I went on baby lays, but
well, because I asked about babies, but I think just the biggest thing, you know, in our conversations about tongue ties is you got to figure out whether you have one. You got to do something about it. I always tell people sooner rather than later, because if you fix something, you don't want to be that 79-year-old, because it's really, really hard. But if you're a parent watching and you think you have a tongue tie, you need to do something about it. But if you have a kiddo who you think has a tongue tie or is snoring or has air, you know, all of those things, you got to wait.
I know.
So we know with the kiddo, because the kiddo we can still make life-changing changes to their craniofacial development and their airway. And that's hard for mamas, because I get a lot of, I call them my sweet spot, my middle-aged mamas who are tired of feeling like poop, you know, they're no energy, gaining weight, you know, all of these things. And then I tell them they have to wait, because in their assessment, they mention that they have a 6-year-old or an 8-year-old who snores and blah, blah, blah. And I'm like,
I know. But it's, as you would agree, it's omnipresent. I sadly say every human has some level of dysfunctional breathing and dysfunctional sleep and underdevelopment and soft tissue impairment. I'm switching out my vocab until otherwise proven. I know that's horrible to say. It doesn't mean everyone's tongue-tied. For me at the beginning, it was like, tongue-tie. That's just one small part of it, but it's...
And you're right, not everybody is, but I feel like when people end up with us, they are tongue-tied. Because people ask me, like, what percentage of your population? And I can count on 2 hands the people that have not had a tongue-tie in my thousands of clients. And that's because I always say I'm the end of the desperation road for people. They get into this rabbit hole, they start looking, or somebody mentions it. And then like most recently, I'm having all these clients where they say, yes, somebody's mom mentioned it to me when I was 7, or so-and-so. Yeah, I remember that. And now they're midway through ortho, and that's such a frustrating referral, because they're midway through
and they've been retracted,
or they've got teeth that have been pulled, or they're midway through ortho and that tongue thrust isn't fixing. So, hey, Carmen, can you fix this? But I did just put in a bluegrass bead, so can you work on that? And I'm like,
well, and how often do you get, and this was something I was going to bring up for you, how do you handle sequencing as far as if you don't have enough room for the tongue?
Good question. So I argue with dentists sometimes that we have the real world, we have the ideal world. And while we all look at the airway, as you know, I always say airway first, it's hard, because like me, I'm wider than and I didn't have a tongue tie, you guys, but I was the world's biggest mouth breather, and you can see by my craniofacial structure. So I have a lot of clients who ideally they need some more space, but they're like me. They have no sleep problems. They have no breathing problem, that kind of stuff. So it's difficult. I have had some clients, and this is what really threw me for a loop, because I have had some clients, you know, that they go to Dr. Zoggy, and I'm like, there is no way they're going to get a release until they have some expansion and that kind of stuff. And then they're like, I got my appointment. And so it just has taught me that there's more to the picture. And some people are like, yes, I want to go on that journey. I just can't do that right now, cost-wise or life-wise, but I want to get my release taken care of. So it's hard, because I have some providers where they say, hey, just send me a snapshot of your client. I'm going to tell you whether she needs expansion first. And I'm like, yeah, but you sell an appliance. And so that's hard. And I always say, I understand there's an ideal world, there's a real world. But I had somebody this week where I said, I will not touch you until you see an orthodontist, you know, because I know that there's concerns. So I'm looking at that multifactorial stuff, but it is hard, because there is that ideal. It's kind of like when you go to the dentist and you get the ideal
treatment plan. Yep.
$20,000 treatment plan, and you're like, but I just want to fix this one tooth right here, and so we all learn to do our job right. It's just like periodontal disease. Do we do a full mouth scaling, or do we just do a one spot, or 1 to 3 teeth, or whatever? So I definitely take that case by case basis. If I have a client who's a hot mess, I'm not going to do anything until I've got all pieces of the puzzle, until I've got that sleep study, and I obviously don't send them for the sleep study. I call it passing the buck, because I will say, I want you to see the orthodontist, or I want you to see somebody like you in airway focused, so that you can pass the buck. so you can be the one to say, and because you're going to look at that. And that's what I always say. I'm a piece of the puzzle. I'm gathering some information. I send, I wrote a 12-page report yesterday. So I send that information. So the doctor gets that and knows, okay, here's my concern. But sometimes people are like, Carmen, it's going to take me 4 months to see the orthodontist. In that case, we could have my release done. We could be, doing all of that stuff. The biggest thing is, and I don't know if you have experienced this, but we cannot do myo and expansion at the same time, because you cannot create a suction. And I've had even one of my big release providers on his daughter. He's like, oh, she's getting her expansion on Friday. And I'm like,
yeah.
So we were stopped dead in our tracks for 6 months because she couldn't do it. So, and that's hard, because when I'm trying to, talk with orthodontists, when I'm saying it has to go this way, we can't have this in the mouth. And then oftentimes I have to do a lot of jointed therapy. So I time out. We'll get a release, especially in kiddos, if they have an airway concern, space, that kind of stuff. We'll get a release, because as they're expanding, I want that tongue.
Yeah.
And it's so hard when I've got kiddo, but if we've got this for a palate, then that has to be dealt with first, So we got to have the tongue in the roof of the mouth. We also have, if we start if we're working on nasal breathing, we can't have that tongue tie. So it's so hard. And you probably run into this because there's just so many pieces of the puzzle. But I always tell parents, like, we have to do it my way. Not that I am the end all be all and that I know it all. I just know that we can't do both.
Yeah,
I can't have a bio block. Now, somebody just asked about doing an ALF appliance during myo. That's easier, because that ALF appliance is a wire. Biggest thing, you guys, is we have to have a suction. And if somebody's got a bio block or some of these other big appliances, let me just say, it's like having a shoe in the roof of your mouth.
Yeah. Although I have to, ALF, Invisalign, and that's a whole nother talk, but Invisalign in little kids, it's actually acting as expansion, not because of the tongue. So that's another cool, anyways, low profile appliance to be able to grow. But yes, BioBlock, impossible. I love the BioBlock. We do BioBlock. I do ALF. But an MSC, I had an MSC in, which is why I have a diastema. It's sort of, you can kind of get suction, but it's not ideal. It's not ideal.
Yeah. And that's what I always say is, I don't want to teach anybody to run and then they get new sneakers. So if I've got anybody with any sort of appliance in there that's going to alter the swallow, it's going to.
It is.
Yeah. I don't want to reprogram or deprogram to reprogram to deprogram to reprogram. So that's oftentimes where I have to do a pause. Okay, let's get some more space. We've had the release. We've got successful healing. Now let's pause. Let's deal with the airway. Then we'll come back and really work on the swallowing mechanics, the organization, the habituation, all of that stuff. So,
yep. Yeah. And it's different, I think, here, because every patient's an airway patient. That's pretty much here in my practice. So I need a bigger nasal floor. So, but it's hard because we usually, like in our office, we usually do a little bit of myo to at least establish nasal breathing while the appliances are getting fabricated. But it depends on where the patient, like if you were to send a patient, they could be, if everything's done in-house for me, I control a little bit more, but that's not a perfect world. And I work with everybody. So
yeah,
but but yeah, it's but one other interesting, I guess we have 2 more minutes, but
No,
I'm gonna take every minute. But interestingly, and I don't know if a hygienist or SLP myofunctional therapist can utilize the technology, but I actually screen all my patients with an HRPO, high resolution pulse oximeter. It gives me an RDI, so I get a respiratory disturbance index,
yeah.
which everybody what that means is it's looking for apneas. But it also gives me something called the autonomic arousal count. So that's how many times a patient goes into fight or flight per hour. So something to always remember, because I know there's other providers, I think, listening to this, but breathing and breathing disordered sleep, it's a continuum. So apneas, that's disease. Mild, moderate, severe apnea, you're diseased. There's still frank disease, I should say. It's there. It's occult. But then you have all this dysfunctional breathing and sleep before you get to apnea. And so that's where I make a big dent in patients. Sorry, that sounds weird. But I don't, when they've already diseased, their neurological system has kaput. Like it's succumbed. And we can bring them back, of course, from the dead. But, well, death is on the far side of severe sleep apnea.
I know.
It's on my pretty slide, it's black. And it goes bright red, medium red, blood red, black for death. Anyways, but the high resolution pulse oximeter lets you confirm but not diagnose those upper airway resistance patients. So it's like you can have a patient with like an RDI of 2, which is you're only suffocating 2 times per hour. No big deal. It has to be 5. But they could have 35, 40 arousals per hour. So their sleep's getting interrupted that many times. But they would just be not even that little boy that you were describing that was sent for the sleep study. Those would be the people that are like, you don't fit the bill. No,
well,
sorry.
Exactly. And before we go, I have the same problem with my youngest daughter is 25. So the interesting thing is you mentioned RDI. A lot of people have no idea about the RDI, the AHI, that kind of stuff. Yeah. Interesting though, when my daughter had her sleep study done, so she was 100th of a point off of mild apnea on her back. But then when she rolls over, they average it out. But she goes through 2 grinding appliances a year. She's got beautiful teeth, but she had retractive pull headgear. So she's got 2 ruined joints, whole nother conversation. But her sleep study shows, and I don't remember what the numbers are, but when we went to see another specialist, he said, so they aren't diagnosing her apnea because of AHI, but if her RDI, on Medicare, my understanding, he said that on Medicare, they use the RDI, not the AHI. And according to her RDI, if she was on Medicare, they would have diagnosed her. So she's 25 and she has night terrors all night and blah, blah, blah. But she's not old enough to, how sad. So we're going to just let her suffer.
And disease.
Because politically, it's so interesting. So I always just get so frustrated with that. But we're talking about RDI. I'm like, yeah, well aware. Yeah.
Well, and my last comment before I say thank you to everybody and to Carmen is I liken airway problems to cancer. So if you have, let's say you don't have apnea, I would think of apnea as stage 3 or 4 cancer. Upper airway resistance, stage 1 or 2. And we don't bat an eye, we don't even bat an eye to treat stage 1 cancer. Like, why would you wait for it to metastasize? Or why would you even you don't want anything festering in your body. So that's my parting comment.
I always say snoring's not cute, gasping's not cute. Open mouth, none of that stuff. So now that we've given everybody stuff to think about,
I know,
by their problems. This is never it's never an uplifting conversation, because when I do an assessment with somebody, I'm always like, this isn't a self-esteem builder, because I feel like I'm like, this is wrong, this is wrong, this is wrong, this is wrong. Thank you for having me. This was wonderful. We got a lot.
Oh, yes.
So we'll make sure and share it over to my page.
Yes.
And thank you guys all for showing up, and thank you.
Yes, thank you, Carmen. Good to see you. Happy Thanksgiving.
Thanks, you too.
Yes. Bye-bye.